It is important to monitor our wound progress or deterioration if there are issues. So that is found on this slide. We're going to go through the steps here. We monitor the status of the wound whenever we do a dressing change. And we should be charting on that each and every time we do that dressing change as well. And for the purposes of the lower extremity wound pathway, we're recommending the use of the NISS wound record. We've been working with NISS to revamp their form, to incorporate extra parameters for measurement, so that allows us to monitor the percentage of wound healing over time. And we'll talk about the wound record here in a little bit. We'll go through step by step. I know some of you in other areas have been using different types of wound records, but we're hoping with this pathway we'll have everyone using a standardized tool, and that being the NISS wound record. So when we do use the wound record, we should be charting each and every time, but we don't need to measure the wound every time unless it's deteriorating. We should be measuring that wound weekly, but if it is not looking so good, we should be measuring each and every time you open it up, okay? So we monitor the wound progression and note if our targets are being met for wound healing or not, and we'll talk about what those targets are coming up. So sometimes clients need ongoing monitoring of the comorbidities to ensure their risk for ulceration doesn't increase again. So when we are meeting those targets or have actually healed that wound, we should be sending them back to primary care, their primary care practitioner, to arrange for follow-up. And Dr. Laboucher will talk about that later on, about some plans for the future with regards to where we go from here for that ongoing follow-up. If targets aren't being met, and sometimes that happens, then the home care nurse should be consulting their wound resource nurse if you have one, or going back to the primary care practitioner and having a chat with them and saying, okay, things aren't going good here. Perhaps we need a referral off to a specialty area, vascular specialty, or whatever that might be. If targets are met and the wound's closed, then great, we have a little party and all is great with our patients. So, all right, so we'll talk about the wound record, the NISS wound record. There's a little bit of it on this slide, but I'll show you here in a couple moments the full form. So the NISS wound record is a form that allows for ongoing charting and monitoring of wounds, and it's the preferred wound record that we're going to use for the lower extremity wound pathway. The reason why we prefer this is that NISS regularly updates their form according to health alerts that come out. A few years ago, they responded to a health alert that came out with regards to wound packing, and the recommendation was that we chart when we put wound packing in and when we take it out, and I'll show you that on the form here in a moment. So I'll bring this up right now on the overhead. So for those of you who haven't seen it, the wound record looks like this. There are 2 pages to it. There are areas to record your information on 3 wounds, and I'll use this pen to point everything out. Hopefully it shows up on our monitors. Up in the top corner here, you'll put the patient identification, whether that be a label or you write it in. Of course, the do not copy and the line through it won't be there when you order those forms from NISS. You will indicate on the diagram here at the top where the wound is, a little simple circle, and wound number 1 next to it. If you have more than 1 wound, is probably a good idea, because down here we do label our wounds, wound number 1, and then on page 2 and 3 there's areas those other wounds. If you're using more than, if you have to use more than one form, because let's say you have somebody with 9 wounds, I have before, you'll just add those extra forms with that. It can get quite challenging when you're using this form and you have quite a few wounds. So sometimes the recommendation I tell nurses is that staple your forms together. The problem would be is if one wound gets changed daily and a different wound gets changed weekly. You may kind of have to cross out some of your forms. That just kind of helps to keep things straight. The other thing I like to tell nurses is on the area right next to the wound number, which is right here, right where that wound is. So if it is the left leg wound, then write that there, okay? And that just helps kind of keep things straight as well. When we start getting 10 wounds, it can get quite confusing. All right, so going back up to the top, we do have goals, and that would be like a palliative or maintenance wound and a healable wound. And a palliative wound is fairly straightforward. Those would be ones that we're not able to heal. Maintenance wounds are wounds that sometimes we can't change lifestyle of our clients, or they're not willing to make those changes, or they might have existing comorbidities that they cannot change that would improve their wound healing. So sometimes we're not able to heal wounds right away. And sometimes it just becomes an educational process, and we work with people and they can make the changes that they need, sometimes in slow increments, and sometimes they'll never make those changes, but we do have that area here that we have to recognize. And then of course our healable wounds, which we hope most of them are. Up in the right-hand corner, we do see wound base, and we're going to, these are all of the parameters that we're looking at when we're assessing our wound. So that is the wound margins, peri-wound skin, exudate type, exudate amount, odor, limb color, and limb edema. And you'll notice on this form that there's tiny little spaces to write. And that's a challenge. I do get comments from nurses that they don't like this form because it is pretty small to write. But what NIS has done is they're giving us the, let's say, exudate type at the top here. They are giving us little abbreviations. So you can just write the abbreviation in there. And as you get to use this form, you'll recognize those abbreviations right away and be able to understand what's going on with that wound. So next we get into treatment type, and you can use, again, the abbreviation. So let's say you're using a gauze dressing. You would write number 3 down here in the square for treatment type at the bottom, which isn't showing up. I'll just move that up for you, right here, and you would write that. Sometimes, though, you want to write exactly what you're using, and I do recognize that these squares are fairly small. So you might, if you have a lot to write, you might just say see progress notes, and then you can write that information in there if you need to. So going through the assessment, you would look at your size in centimeters, length times width, and then what we've added to this NIS form is the surface area. So you're taking the length and multiplying it by the width, and that's giving you the surface area. And you monitor that over time, and you will be able to note the percentage of the change in that surface area. And with our wounds, we want to have a 50% decrease in the wound size within 4 weeks for it to be on track. If it's not that 50%, then we have probably a chronic wound at that point in time, and we should be perhaps getting a hold of a wound resource nurse or some other specialty such as vascular if that is the need. Okay? Going down, we have the depth in centimeters, undermining in centimeters, and then pain. If you have someone who has quite a bit of pain, we probably should be using a pain tool. And often in health regions, we do have specific pain tools that we use that we can assess that person's pain. Wound base and then wound margin, and again, you'll refer up to the top for your parameters that you'll put in there. Then peri-wound skin, exudate type and amount, odor, limb color and edema, your pressure ulcer risk. Now the pressure ulcer risk, you should be looking at the Braden scale for that. And so you should know for every patient that is admitted to a facility or an agency that we should be doing Braden scales. And your health region will have a specific policy that will vary, I think, a little bit from region to region with regards to home care. But know what your policy is with regards to pressure ulcer risk. And if you are to be doing that Braden scale or the Norton scale, then make sure you're writing that in here. So we do kind of keep track of that. And again, we talked about the health alerts that come out. This is the area here with regards to the packing where they included it now for insertion and removal. We need to be very specific in documenting exactly what we're putting into wound cavities and what we're taking out so that we don't leave anything behind. Okay. Then if a swab was taken, we can just put a check mark in this area. And if a photo was taken, this is a new little area that is included as well that we have now, and we can put a little check mark in that so that the nurse knows, okay, 2 weeks ago we took a photo and we're going to have a quick look at it so that I can compare what's going on now. And then see notes. So if you're writing anything else in the progress notes, you're going to just put a check mark there or initial, whatever you wish, and then sign at the bottom. Okay? So that is the NIST wound record. The long-term plan for the pathway is that we have some sort of electronic record that we will be able to use computers on. Ideally, we have something that would do the assessment, the monitoring of the wound, and it would automatically calculate that wound surface area. And the wonderful thing about these electronic records is that they'll cue the nurse that there's an issue. Targets aren't being met for wound healing, and a flag will come up and say there must be a review. So until that point in time, you have to find something in your agency that you regularly review those areas if those targets aren't being met, okay? So I think that's all I have. Carolyn, oh, no. I need to talk about what nurses need to know. No, you need to talk about next. Sorry.
Okay, well, let's see what our next slide tells us, and maybe we'll know who's talking about what. Okay.
What happens in specialty care?
What happens in specialty care? I guess that's my slide. So this slide is referring it's speaking to what happens to the patient when they come to the acute care site. For example, when the patient comes to see the vascular surgeon here. So it might be someone who's coming in on an outpatient basis, or it might be the person who is referred on an urgent basis and sent to emergency. So that treatment is coordinated by the vascular surgeon. And at that time, that's where the vascular surgeon will perform their assessment, and based on findings and severity of wound and all those other parameters, treatment will be planned. Perhaps it's surgical intervention if it's a limb or life-threatening wound. It may be revascularization if that's an option. If the person comes into the outpatient department, we will review and determine if we need to refer on to any other service, or if we need a review by, let's say, the orthotist to review the footwear or something like that. So, you know, everything will be reassessed, and we'll look at the plan and make any adjustments so that we can move, you know, we can progress. So local wound care will be provided, and we'll write new orders if that, and like I said, we'll often reassess things like offloading. So after that's all done, if it's in the outpatient setting, the patient or client will be referred back to the regional home care with orders, and the expectation is that care will continue as ordered until that patient comes back for review again. So when these patients are being followed by the vascular surgeon, they write the orders and they plan the treatment, and the expectation is that it will be followed until they come back for reassessment, or unless there's some urgent change in wound status. Okay, so our next, I think that answered most of those questions, and I think I went through that pretty well. So the last slide I'm going to talk about is the multidisciplinary team. So it takes a team of people to heal a wound. I can't do it on my own. I need support from my colleagues. I need the physician involved. If it's a diabetic foot wound, we need a variety of people. We need the orthotist or the podorthist to review offloading and footwear. We may need the podiatrist for callus debridement and management ongoing. You know, some people require the services of a social worker or nutritionist. Really, you know, we need to look at how the wound is progressing and what we can do to make, you know, to either facilitate progress or speed things along and determine who's the most appropriate person for that. So, you know, collectively, when we work together, we have much better results than when we work in isolation. And Michelle, I think the last slide's yours. Yeah.
Okay, so what do nurses need to know? Well, Carolyn was just talking about the team approach. It does take a team approach to heal a wound. We can't work by ourselves, although sometimes in rural areas we do feel like we're working alone. But try and access those team members by even phone if you can, even just to have a chat with them. And definitely access your wound resource nurses if you need help. And if you don't have a wound resource nurse, then talk to management and tell them how much you need a wound resource nurse, okay? So if the vascular surgeon is directing is directing local wound care treatment, know that they're going to follow up with those patients and that they will be following up and doing regular checks, and if something's not working, then they will see that person and make the changes that need to be made for the treatment, okay? The hopes in the future is that we'll be able to have people seen by telehealth, and we're investigating that possibility right now and working with the vascular surgeons so that people don't have to travel. And it is a great challenge and a hardship sometimes for people to travel. And we recognize that, and so that's why we're working to increase that capacity out to those rural areas, okay? So with capacity building that I alluded to, we have worked with Sask Polytechnic in the development of a course for nurses. We recognize that not all nurses will have experience with lower extremity wounds, and we wanted to bring them education on how to identify and treat those lower extremity wounds. The course is a comprehensive 12-week curriculum which provides nurses information on wound healing, assessment, identification of wounds, risk factors, treatments, and prevention. At the end of the course is a 2-day lab and that allows nurses to practice the skills that they've learned about in the curriculum, such as assessment, wound measurement and cleansing, treatment and dressing selection, ankle brachial pressure index testing, and compression wrapping. Once completed, nurses returning to their health regions must still comply with their scope of practice and standards, as well as policies within their health region for special nursing procedures. So this doesn't certify them to be able to go and do ankle brachial pressure index testing. Okay. The current session for the course has already started. It began on March 7th, and there will be 2 more sessions available this year, one starting in late April, so that registration is open at this point, and then one in September. There's funding provided by the Ministry of Health for nurses to take this course this year for health region employees, preferably home care nurses that maybe are interested in being those designated home care nurses in their agency. So to apply, you go to the SAS Polytech website and continuing ed and look up the Nursing 1684 care of the patient with lower extremity wounds. Home care managers in the health regions have been given the information about reimbursement from the Ministry of Health, and so if you are interested, see your home care manager. If they aren't aware, we'll give you the information of where you can find that at the end of this. You can contact Lori Latta and she'll be able to get that information. And lastly, resources that you might need for this pathway can be found just by Googling the Saskatchewan Wound Pathway. Lots of information comes up, or you can go to the sasksurgery.ca website and you can find all of that information that you need.